Good day, ladies and gentlemen, from a lockdown Brisbane, Australia. And it's my pleasure to talk to you about something near to my heart, therapeutic drug monitoring. What I'm going to try and do is convince you in the next 25 odd minutes is that it's important to do such for many of the drugs in sepsis. The way I'm going to structure the talk is to use an introduction, particularly of PK and PD. I'm going to talk about the changes that occur in the septic patient, particularly those in ICU. I'm going to talk about augmented renal clearance, changes in volume of distribution, changes in protein binding, renal replacement therapies, therapeutic, and leading in, because of all of those problems, leading into why therapeutic drug monitoring is so important, and then give you some take-home points. So let's start off. Pharmacokinetics describes the concentration time profile of the drug. Concentration time profile of the drug. So if I give a drug to a patient, there's a rise in serum concentrations to a peak, and then there's a drop-off depending on volume of distribution, clearances, etc. Pharmacodynamics, however, correlates that yellow concentration to the antibiotic or to the drug efficacy, antibiotics' ability to kill the target pathogen. Concentration effect is pharmacodynamics. So PK is dose concentration, PD is concentration effect, PK/PD is dose effect. If you look at it glibly, PK or pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body or within the body. A lot of these concepts come from Bill Craig's original descriptions, and this is 23 or 24 years old, but he's still a hallmark paper where he goes through drug concentrations, pharmacokinetics, and then he looks at pharmacodynamics is the concentration effect or the antimicrobial effect versus time. And when you look at that, you then can see the kill characteristics of the antibiotics differ. There are two big classes of kill characteristics. This is the aminoglycosides on this graph here. If you look at colony forming units on that axis, and you look at time on that axis, standard colony forming units will grow, the control will grow at that rate over time. If you add a little bit of gentamicin, the colony forming units will be killed off in the green curve. And if you increase your concentration of gentamicin at the colony forming units, so you'll kill off the colony forming units quicker and they won't regrow. That's concentration dependent killing. The beta-lactams, however, are different. If that's colony forming units there and that's the control growth, if you have a certain concentration of beta-lactams, there'll be a slow continuous kill, but increasing the concentration will have no increased kill effect. And that's non-concentration or time-dependent kill of the beta-lactams. And if you look at this axis, you look at this graph over here, the yellow curve being the pharmacokinetic or the serum concentrations over time. If you add an MIC to that, concentration-dependent killing depends on the Cmax to the MIC, and the time or non-concentration dependent antibiotics need a long time above the MIC. Now the pharmacodynamics, which correlates the concentration effect of the drug, is difficult to measure with antibiotics. In other words, you give the antibiotics and, well, you think they're working, you're not sure, but the concentration effect is difficult to measure with antibiotics or antifungals or antimalarials. Antimalarials may be a bit easier, but it's certainly easy to measure the pharmacodynamic effects of noradrenaline. You titrate that to a blood pressure. You titrate a dose of insulin to a glucose level. So those pharmacodynamic endpoints are easy. Antibiotics and antimicrobials in general, difficult to measure pharmacodynamics. Now what happens in sepsis and in ICU with the pharmacokinetics that I described. So the first point, and this is an important point, drugs are discovered either in a test tube or in a computer, or they're found and they're put into animals largely to look at toxicity. To some extent, pharmacokinetics, so they can predict from the lack of toxicity in the animal to a dose given to human volunteers as a phase 1 study. Now, these aren't sick people. These are often medical students that need money, but you give the drug to see largely if the drug's toxic. You monitor liver function, you monitor a whole lot of other function to look at not only pharmacokinetics but toxicity. Obviously, you can't. Then the phase 1 study, the patient's not, or the volunteer's not sick, so you can't look at efficacy. And then once you worked out the pharmacokinetics and it's safe, you then give it to phase 2 and phase 3 studies where there are sick patients involved, and you work out the dose and the effect. I point out to you that in the sick patient, be they ward sick or even ICU sick, hemodynamics may not be normal, their liver and blood flow certainly may not be normal, and there's leaky capillaries, and we often then drip patients and put pipes into every orifice and make our own orifice. And then, if you look at this type of graph or this type of picture, you'll see that why would the standard pharmacokinetics be the same as in this patient? So we looked at conceptually this problem where we said sepsis may have normal pharmacokinetics, normal serum concentrations, but there are a lot of patients in ICU that have end organ dysfunction, decreased clearances, resulting in a high plasma concentration. However, there's a group of patients that have normal function, so-called normal organ function, will have leaky capillaries, increased volume of distribution, and increased clearances. Now, this type of end organ dysfunction still can have leaky capillaries, but the clearances will be less. Here, if they've got normal organ function with this leaky capillary, you'll also have increased cardiac output, increased clearances, and low plasma concentrations. Compounding that in ICU, you add extracorporeal circuits, and it's even harder to work out pharmacokinetics. So let's look at augmented renal clearance first. So here, increased cardiac output, so no organ dysfunction, sepsis, hyperdynamic circulation, there's an increased cardiac output, increased clearances, resulting in low plasma concentrations. And we looked at that and, in fact, showed convincingly that in the first big set of papers in 2003, where we looked at cefepime pharmacokinetics in 12 ICU patients with normal renal function, cefpirone in 12 patients with normal renal function, and plotted creatinine clearance on that axis, measured volume concentrations and volume outputs, urine concentrations, urine outputs, and serum concentrations. And we looked at drug clearances on that axis. And you and I, as we sit here, if you've got normal renal function, have creatinine clearances of about 100 mils a minute. We'll have clearances over there. But there's a group of patients in ICU that will have significantly higher creatinine clearances than you and I, up to 200, 300 mils a minute. That will result in significant drug clearances and significantly low troughs because of the drug clearances. And we coined the term augmented renal clearance with one standard deviation above the normal, above the higher limit of normal, about 120, one standard deviation above that. We said augmented renal clearance are those patients that have creatinine clearances greater than 130 mils a minute. We then looked at patients who come into ICUs with normal serum creatinines and asked the question, how many of the patients in multidisciplinary ICUs in Portugal, in Singapore, in Hong Kong, and in Brisbane, how many patients in multidisciplinary ICUs that come in with normal serum creatinines have augmented renal clearance? Right? And we showed 65% of that cohort had augmented renal clearance. if they come in with augmented renal clearance, they actually maintain that augmented renal clearance for up to 7 days. And we actually only stop measuring at 7 days, so it may go on for longer. The group in Ghent, Jan de Waal's group, asked the question of, in a multidisciplinary mixed surgical medical ICU, all patients on antimicrobial therapy, how many of those patients have augmented renal clearance? And they showed that 51% of a standard cohort in ICU, mixed ICUs, would have augmented renal clearance. We also looked at a large group of patients in 68 ICUs across Europe, almost 400 patients, and all we asked for from the treating physicians is to send us trough and midpoint serum and trough serum, and we would measure the beta-lactams, and this is the results: concentration on that axis, a whole lot of antibiotics on that axis, and you can see there's a group of patients that have significantly low levels in ICU. Now this is all comers with renal dysfunction, without renal dysfunction, but you can see on standard dose or on whatever dose the physician chose, there's a significant cohort of patients that have low serum levels. And it's this augmented renal clearance that causes that. Often younger patients with inflammatory response and normal renal function, they come into ICU or they're in the hematology wards or in the burns wards, and their blood pressure may be a bit low, they're hyperdynamic, so you give them fluid. And you may, in fact, give them inotropic support as well to defend the blood pressure. And it's this that increases the cardiac output even more. With normal renal function, increases renal blood flow, increased creatinine clearance, increased drug clearance, low troughs. This has been reviewed a number of times now. There are probably 5 or 6 articles. This was one of the first big reviews, 2018. And all the reviews would show the same. Younger polytrauma patients, often patients with normal renal function or maybe head injury, single organ dysfunction, but normal kidneys. So the 2 big problems in ICU, 2 big pharmacokinetic changes in ICU, as we've said, increased clearances, augmented renal clearance. If that's the old yellow curve, the blue there, and if you have increased augmented, or if you have augmented renal clearance, you land up with a green curve for the same dose. There's also increased volume of distribution in a lot of these patients. So here, the yellow curve, or blue now, if you give a standard dose to a patient, you'd get the blue curve. If there's increased volume of distribution and you give the same dose, you get the green curve, much lower peaks and lower total area under the curve. So you really, in these sick patients, have to volume load. Now, even if the patient has renal dysfunction and they have got leaky capillaries, you have to volume load initially to get adequate serum levels and then worry about clearance later. But you need to have an increased drug concentration to fill up all these spaces for the capillary leak. Now, put it to you, how often have you needed to change your levels of vancomycin after initial dosing? Well, I'll put it to you, quite often, and the reason for that is that vancomycin has a large volume of distribution, so you've got to give a large dose, you've got to give a loading dose, and vancomycin has mirrors creatinine clearance. So with augmented renal clearance, you're just peeing out your vancomycin. So let's look at protein binding. The Australian-New Zealand trials group, ANZIC's trials group, did a 7,000 patient comparison of saline versus albumin for fluid evaluation, but it's actually fluid resuscitation. So all patients came into ICU, were randomized, if they could be randomized, into either getting albumin for resuscitation or saline for resuscitation. 7,000 patients. The important point here is that of those 7,000 patients, 40% have low serum albumin. So 40% of this 7,000 patient cohort come into ICU with low serum albumin. Albumin is the main protein binding compound in most drugs. So there's low serum albumin, low protein binding. Now, we did a study in 2001 in Hong Kong where we looked at 12 patients with normal serum creatinines and ceftriaxone. And we showed that total ceftriaxone dropped quite significantly in some patients over the 24-hour period. But more importantly, we also measured free fraction of the ceftriaxone. And that, because there's lowish albumin in ICU, there's a lot of free drug. It's the free drug that goes out in the kidney. And although the total ceftriaxone level didn't drop that much, or some of them dropped, but not all the time, the free fraction dropped dramatically. And what was left over here was just bound ceftriaxone. And that doesn't cross membranes and is the inactive compound. So it's the free fraction that's the compound. So here, within a few hours, most of the free fraction is out through the kidneys and compound is less effective. We also, this is a case study, we looked at ertapenem. Standard dose apparently is 1 gram a day. We measured levels. It was very low, so we increased the level to BD. We measured the level again. It still was low. We increased to TDS. And we still found less than optimum levels. So we had to give TDS ertapenem plus an extended infusion. And only then did we add adequate time above MIC. We reviewed this in 2 different articles, 2011, and then with Frederica P. giving more clinical relevance in 2013. All right, let's look at renal replacement therapies with this extracorporeal circuits, and even harder to predict PK and therefore PD. And one of the problems is the dose of CROT and the setup in ICUs, although we do it every day, differs from ICU to ICU. And if you think you got dosing correct, you got problems. I think none of us really know how to dose on the CROT that you use, because you use different standard procedures than I use. I know that in a hospital a couple of kilometers from us, they set up the CROT circuit totally different to the way we do. They clear the urea and creatinine, but their clearances are different. So we all think we're clever. We put blood across the semipermeable membrane and have dialysate and ultrafiltrate across that, and we take off the bad guys that the kidneys normally take off, urea, creatinine, etc. But there's CVVH, there's CVVHD, there's CVVHDF, there's SCUF, there's SLED. And all of them, although removing toxic products of metabolism, would remove other compounds as well. So we would all of them will remove water, electrolytes, some of the products of metabolism, urea, creatinine, etc. Some drug toxicities you'll take off, but it also takes off the good guys. And we don't know how much, for example, meropenem or peptaz we take off in the CRRT. And then when I do my rounds, I see the CRRT machine on. And then I go home at night and I come the next day to do rounds and the CRRT machine is on and I think everything's okay. But then when I look more carefully, for 6 hours, for example, at night, the kidney had clotted and their new circuit was put up. And the nurses are busy, so they can't set up the circuit immediately, so they take a few hours to set up the circuit. And for example, 4 to 6 hours at night, there's no CRRT machine on. Now, the CRRT itself will clear drugs and waste products and drugs that we want in the circuit. But then when the machine's off, there's no clearances. So, in this review with Bruce Muller and Gordon Choi, we felt that the only real way to have effective antibiotic dosing receiving different RRTs is therapeutic drug monitoring. That's the only way you could be sure that we're getting effective levels, or we use it for efficacy, but also to see that we're not giving toxic levels. So just to summarize this part, the differences in PK in ICU are increased volume of distribution, increased cardiac output, increased hepatic renal blood flow, low protein binding, and hence free fraction of drugs are high initially, increased clearances, and renal replacement techniques. So that's the differences of the PK effects in ICU. So I hope I've convinced you that in severe sepsis, particularly in ICU, you can't predict the pharmacodynamic effects of any pharmacokinetic results of a drug. So we believe that you have to use therapeutic drug monitoring for it. Now, therapeutic drug monitoring refers to the analysis and subsequent interpretation of drug concentrations in biological fluids. And it's used for two big effects: to maximize efficacy and to minimize toxicity, to personalize drug dosing. So you use it to minimize toxicity or maximize efficacy, or in fact both. Now, aminoglycosides and glycopeptides have been available for measurement in a point-of-care rapid turnaround immunoassay because everybody was worried about toxicity, and there was a big market to minimize toxicity when using aminoglycoside and glycopeptide. The therapeutic ratio, the toxic effect of beta-lactams are limited. However, you can get toxic effects of cefepime here in the study. You can get neurological neurotoxicity. Imipenem does similar neurotoxic effects, and even with penicillin you can get neurotoxicity. So therapeutic drug monitoring allows you to measure your pharmacodynamic endpoint of serum concentration. Now, with diabetes, you would never give insulin without monitoring glucose. So with antimicrobials, you're really shooting blindly when there's altered pharmacokinetics. And most sick patients, really sick patients, unless it's in the same cohort as the phase 3 study, you're going to have different pharmacokinetics. Admittedly, I'm biased, but I would never give insulin without glucose, and I would nowadays never use beta-lactams or aminoglycosides or antifungals. I seldom use anti-parasitic drugs. I would never use them in a difficult to monitor patient without measuring levels. So we reviewed this, all anti-infectives, a couple of years ago, and we basically, just to review, in ICU, there's organ dysfunction with decreased blood flows and therefore possible toxicity if you don't decrease the dose. It's more complicated when you have extracorporeal circuits. And there's a group of patients with increased renal blood flow, increased hepatic blood flow. So increased clearances of antimicrobials in general. In burns particularly, there'll be increased clearances and fluid losses through the burn wounds. And then you'll have capillary leaks and increased volume of distribution. And what we've set up many years ago now is chromatography, HPLC, where we on any sample can measure, on a single sample can measure any of 12 different beta-lactams. Other people have done similar. Here, 8 beta-lactams on one sample. So you send your sample in the morning, you run it through these machines, and you'll get your result a couple of hours later. It's not point of care. It's not real. It's not within half an hour. It may be 4 or 5 hours, but you can measure beta-lactams quite easily. So, in summary, the take-home points. Many years ago, we showed that exposure to low concentrations of a drug would allow bacteria to become resistant, and initially it was thought resistance to quinolones are the main problem, but we showed here that it's resistance to all drugs if the concentration at the bacterial site is low. So the bacteria the wussy or the weak bacteria are killed, but the resistant ones will grow up and eventually become the dominant organism. Beta-lactams, be it safe drugs, have large therapeutic range, so it's been easy to administer, but we are now using TDM to maximize efficacy of the beta-lactams. Occasionally you may use it for toxicity, but by and large you use TDM for beta-lactams to maximize efficacy. We reviewed this with a Swiss group, showing that although you may not need it in all patients, in populations that have grossly varied and unpredictable pharmacokinetics, you really should have beta-lactam TDM. It's not difficult to do. We've set it up. We now measure free beta-lactams. Here's another group that are setting up the same thing. So it can be done on a single sample measuring any of a number of beta-lactams. So in conclusion, for various reasons, we are using TDM for most antibiotics, and it's not impossible to do. We have set up a service for all our beta-lactams, but also our antifungals as well, and it's shown that more than half our ICU patients, we have to adjust the dose once the drug level is back. I thank you for your time and attention.